Welcome everybody to the Random Anesthesia Topic podcast. In this episode we have Dr. Natasha Bartel from King's Animal Hospital in Ontario, Dr. Ryan Bailey from Premier Veterinary Group in Chicago, and I'm Dr. Gianluca Bini, owner and founder of Safe Pet Anesthesia, a training and teleconsulting company, and I'm an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. What's up, Ryan?
Wow.
Happy St. Patrick's Day.
Oh my god.
Yeah, it's so funny that we're all in green.
Is there anyone else on the stream right now, or is it's just me, right?
It's you and us, yeah. And you're the only one with the real mustache.
For me?
Yeah, this whole mustache situation is not something that I'm enjoying. It's making my upper lip sweat excessively.
It's so weird.
Most of my free time making sure that I'm not growing a mustache. So this is a real low point for Bartel.
Oh my god.
Awesome.
I love it.
Awesome.
This made my day. Very, very nice. Very nice.
Yeah, we've been planning it for a while.
So technically this was supposed to happen. So whoever is listening, me and Dr. Bartel are actually wearing a fake mustache to mimic Dr. Bailey's mustache. So you can watch us on YouTube or Apple Podcasts. But we were planning this for the previous episode before
Valentine's Day.
Dr. Bartel's
was late, and so we couldn't surprise Dr. Bailey. Yes.
Exactly. She was late. She forgot.
I'm never going to hear the end of this. I just know it. I just know it. Also, anyone who is watching, I don't want you to think in any way that we condone mid-20th century maniacal. This is strictly to mock Dr. Bailey.
I am well mocked. The mustache stays.
Oh, do we have to wear for the thing?
It's up to you. We bought a whole collection of them.
I don't know how you put up with this. It is awful. Like my mouth is so hot. It keeps catching things like that are flying, like cat hair flying through the air. I'm heading straight to the beauty salon tomorrow and I'm going to wax everything except the top. Yeah.
Oh my god.
It's crazy. All right. So tonight's topic, it's going to be picked by Dr. Bailey, right? Mm-hmm. What you got?
So given the discussion last month, I feel like I had to talk about lidocaine, its utility, like when are we using
futility,
it?
You mean?
What?
You forgot an F there. It's futility.
God, Bailey, we just got burned by
kidding.
which is Italian.
Oh my god.
I'm kidding. It has its uses.
I want to know, when are you reaching for it? Is it
for it to numb my upper lip from this mustache? Can I please take this off now?
All right.
Yeah. Bailey, I interrupted you, which is totally my jam. But anyway, lidocaine, what are we reaching for it? What's its utility?
Yeah, like there are, I feel like there are people who I have worked with who I think feel lidocaine is maybe wonder drug is a strong word, but there are people who swear by it. Everything gets like a lot of things will get lidocaine in some people's care. And to find someone who's so vehemently against lidocaine, I gotta know. I want to know, like, How do we all feel about it? Are we in the it's a wonder drug? Are we in the it's a useless waste of a pump, if you will?
Waste of a pump. That's our new insult for other clinicians that we don't like, by the way. This question is almost exclusively directed at Gianluca, so I'm gonna let him because also my confidence was shook last month when he came down so hard on lidocaine that I'm now afraid to express an opinion. Although it's a lot of big talk until something goes into VTAC anyway. But yeah, Beanie,
Right.
you lead this charge. You're the lidocaine revolutionary. So what do you do?
No, I'm not. I'm not. I mean, I, as I said last time, I think it's, I tend not to reach for it as my first choice. Can it be an addition to other drugs? Sure. But like if I have to pick, if the reason why I need an extra drug is analgesia, that's not my first pick, right? Um, there's a bunch of drugs that are MAC reducers that are not analgesic, like propofol or Faxon. Those are MAC reducers. They're not analgesics, though, right? Same with marobidine, right? It decreases MAC, no analgesia. But in reality, I feel like if I have to pick an analgesic, I try to find something that I think it's a little bit better, like Dexmed or an opioid or ketamine. If I'm looking for like an anti-arrhythmic, like especially for ventricular arrhythmias, of course, like yes, lidocaine is definitely your go-to usually. In some horses, like for colics, it's totally fine. The anti-endotoxemia story, I can buy into it. It's fine. You know, the I was discussing this with actually one of my VTSs today, and she's an amazing tech, and she has a VTS. She's been doing this for like 20 plus years, right? And bouncing ideas back and forth. In reality, for some foreign bodies, maybe you don't really want to reach for lidocaine, right? Because of the pro-kinetic effect, and the fact that if you depends on what kind of foreign body it is. It may or may not be beneficial for that dog, right? If it's like something metallic and it's in the intestine. So I don't know. I think it has its uses, right? But it's not usually my first pick for analgesia. If we're looking at pure MAC reduction, sure, maybe with an FLK, the usual fentanyl, lidocaine, ketamine, done plenty of that. But at that point, I think there's better macro users too. You know, uh, for me, it's a kind of that drug that's a good addition, but it's a little bit in the back burner sometimes. It's not my top pick. Maybe because I don't use high enough doses, right? Like there is people that like again, as we were mentioning, they end up with 200 or 100 mic per kg per minute of lidocaine. Then maybe you do see more beneficial effects, I guess. But
Yeah. I will say this about lidocaine is that I don't disagree with Gianluca. I think that in terms of if I have a patient who's either getting light or is a little too light on the table, like we have increased abdominal tension, we have bucking of a ventilator. It's extraordinarily rare that I would reach for lidocaine as my first choice for a rapid increase in depth of maintenance plane. The other thing I have to say about lidocaine is that if I were to pick a drug that I have had problems with cardiopulmonary arrest and things, quote, dying off the needle, lidocaine is probably my personal number one. And I don't do crazy things. Like I don't whack in large boluses really quickly. Like I have had things where I've been giving lidocaine and specifically in an anti-arrhythmic capacity and even at like 0.25 mg per kg given slowly, they've arrested on me. Now, correlation is not causation. So whether the lidocaine was incidental to that or was actually the cause of the arrest, I will never know. But I've also been called frequently to a number of local anesthetic toxicity cases. I'm really going to highlight the dentists here who sometimes just hose gums down, not even knowing what toxic doses are. They mix local anesthetics. They do all sorts of wild stuff. You may have a CRA of one local anesthetic, and then, you're topping up with regional local anesthetic elsewhere, which is technically speaking a no-no. So I have, a number of cases where I've had to go into a local anesthetic toxicity arrest. And those ones are more challenging to get back than like your straightforward, like I left the APL valve closed or I got really bradycardic and just went into sinus arrest type situation. So lidocaine for me, I think it gets bandied around really loosey-goosey lidocaine, but I have a healthy respect actually for how dangerous it is. And like I said, isn't my first line in any capacity. So analgesia, in MAC sparing, it's not. Right. And then prokinesis, like the bulk of those papers are equine. And the other thing too is the bulk of the small animal papers are in vitro studies, not in vivo studies. So is there a pro-kinetic effect? I bet you we could, get a room of nerdy anesthesiologists together and you'd probably end up with a reasonable divide. How potent is that pro-kinetic effect? I don't think we have any data on that. And then, I always say clever things like, it scavenges free radicals and it prevents against reperfusion injury. But those are all extrapolations from human medicine. And I really can't tell you the data in that. We also have some wild opinions about lidocaine, quote, toxicity in cats. And I just want to clarify this point because it is one of those bones I got to pick. It is not lidocaine toxicity. It's that cats have a lower toxic threshold for lidocaine, right? Because there are plenty of times where people use lidocaine for a cat neuter or a quick lumpectomy, and the cats are not just dying all over the place. So it's just people need to be cognizant of the fact that certain species have different thresholds for toxicity. And there are people who will run lidocaine CRIs in a cat, and God bless them and their large gonads. But I just, I'm not one of them, but I don't think lidocaine is the end all be all. And it's rarely my primary drug. It's more so my adjunct therapy. Bailey, how do you feel about it? What are your thoughts on lidocaine and mustaches in general?
Mustaches, love them. Lidocaine, it's a tool in the arsenal, and to your point many moons ago, like there's no reason to have a favorite drug or to prefer one drug over another. Like lidocaine's a tool in the toolbox. Like to me, advantages are it's a non-controlled substance. So in some clinics, it's easier to grab off the shelf without going through a bunch of hoops to get a controlled drug to then worry about waste and
addiction, theft. It's also cheap,
exactly.
right? Well, at least it is in Canada. It's very cheap and cheerful. So if you do have a cost limitation, I think that's a reasonable consideration.
And it's a drug you should be really familiar with and really comfortable, because if your patient goes into a ventricular arrhythmia, you sure as shit better know how to use lidocaine. And if you're like, this is my first time using it ever, it's like, that's not the situation you want to be using lidocaine for the first time. I mean, it's absolutely the situation you should be using lidocaine, but like having a passing familiarity is really important. Theoretically, I love the, literature from people much smarter than me. They're like, it's maybe anti-inflammatory and maybe it helps with like inflamed GI tracts and helps with like some kinesis following like all the inflammation we create during surgery. Like, love it for those reasons. May or may not be a MAC reducer while also reducing cardiac output in the same way isoflurane reduces cardiac output. So like the magnitude is equal, so the MAC reduction is irrelevant. Like, yeah, it's a fair point.
Yeah.
I think
Thoughts on lidocaine and venodilation and hypotension, because I feel like this is a very big deal, for example, in horses, right? Like nobody rocks a lidocaine CRI in a horse until you've basically normalized blood pressure, right? Like, so if you have a colic on the table, lidocaine, really one of the contraindications, quote, end quote, is hypotension. We don't really fuss about it, though, in small animal nearly as much as we do in horses. I mean, I always, if I'm coming in and something's like really like pooping the bed and they're pooping the bed from hypotension, that's mostly vasodilatory. I don't care as much about, for example, like hypovolemic, but I mean, I care, but just not in this capacity. Just to be clear, hypovolemia, who cares? But, I'll usually be like,
Sorry, I needed it.
that's basically how hypovolemic anesthesia goes for anybody listening. It's just like a slow descend into a minor key. But lidocaine is something I would stop as a consideration. So why do we focus on it so much in horses, other than obviously horses have a higher morbidity, mortality associated with general anesthesia, period? Or is we don't have the evidence in small, or we just don't think about it? Are we just lazy?
I want to jump in real quick. I will never forget. We brought a journal club to my residency, and it was about lidocaine and macroduction and this and that. And the way the faculty jumped all over and were like, the amount of macroduction you get and the magnitude of cardiac output depression from lidocaine is equivalent to the isoflurane you're replacing. So by adding a lidocaine CRI, you do nothing beneficial for the patient. And I was like, damn. So I have a healthy...
I sat through the same group of faculty and journal club, and they said exactly the same thing about alpha-2 agonists. So I'm wondering if they just template everything because they're really into inhalants. But yeah.
It sounds like they think it's a waste of a pump.
For sure. For sure. And yet I still use it. But I will say, there are too many patients to count where I'm like, oh, I am really struggling with hypotension here. Let's just stop the lidocaine, and then boom, 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 everything's all better. So when it works, it's nice, but not every patient can tolerate it. And I think being willing to stop it when it's, those theoretical anti-inflammatory, free radical scavenging, blah, 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 maybe it's not the right thing for that patient in front of you.
Well, how much does free radical oxidative cellular damage contribute to mortality in veterinary patients? Side note, neither of you can answer that because none of us know.
Oh, yeah.
So,
whenever they die, we always say it's
because it makes them smart, but I really don't know where this shenanigan started and really what clinical relevance it is. But yeah, I stopped lidocaine in the face of refractory hypotension 100%. The other problem I have with it is it makes tissues poofy. It basically generates tissue edema. So if you ever actually pay attention to how we put lidocaine topical on cats' larynxes, even though lidocaine is toxic, and the one spray dose for sure exceeds the toxic threshold, and yet somehow none of those cats die. Look at their arytenoids a few minutes later and notice how edematous they've actually become. And I think and this is before everyone's traumatized by trying to intubate a cat. This is strictly because of the lidocaine. So there is tissue edema associated with it, and it's probably because of the venodilation, and also there is hypotension. And like I said, you can acutely cause something to arrest because if you sodium channel block heart cells, they just don't beat. So yeah, I don't know. Lidocaine is, I will say this out there for the local, regional, and neuraxial enthusiasts that obviously it's, the local anesthetics are irreplaceable from the point of view of, regional limbs and what have you. But systemically as a CRI, it is a different kettle of fish. I don't think it carries the same oomph that it does for neural anesthesia. So. But yeah, we talk about it as the hypotensive agent in dogs, whereas we're super paranoid in horses.
I love how Ryan was hoping that it would jump into this conversation and somehow you would be his sidekick, right? And then actually what ended up happening is that the table turned and we're both shitting on lidocaine that he loves so much.
I wouldn't say I love lidocaine. So I've gone places and lidocaine's part of their co-induction sequence, a regular co-induction, which is
yeah, why not?
there's papers on it. And like, if you want to bring up a next topic, we can bring up why Tasha hates benzodiazepines, but yeah, like, but, barf. But yeah, I mean, I love a good dose of ketamine. I'm not personally, but as my co-induction agent, but sometimes it's not the one I reach for. And I do reach for lidocaine instead. And it is published, just so the listeners know. It's not one of these like malarkey type situations that we all just collectively believe, but nobody actually cares to substantiate. So yeah.
So when is it that you're reaching for lidocaine as your co-induction agent?
Let's say, Bailey, that I already have a patient that I know is going to go on a lidocaine infusion, for example. Like, and this will be fuck you. And then this will be, for example, I hate you. This will be for a patient, for example, who's arrhythmogenic and is not responding to or is not sustaining sinus rhythm in the face of intermittent bolusing, right? So like, let's say a splenectomy, right? Who's like highly arrhythmogenic. I actually don't often see them being that arrhythmogenic until post, but for the sake of this argument and making me look right, I'm going to pretend that happens. So I might use my co-induction agent in that case because they're already arrhythmogenic. So maybe I'll be a little bit more gun shy about ketamine. I hate benzodiazepines, and I'm going to put the infusion. So I'm cheating and using it also as my loading dose, right? So that'd be one indication. If I felt like my favorite. Yes, Beanie?
No, sorry. I didn't want to interrupt you, but so why do you hit benzodiazepines again?
No, you have to pick that at your next podcast topic, okay? Because they don't do anything. Fuck, they're just such a waste of time. But like, other than anti-epileptic,
it's a waste of a syringe. Waste of a syringe.
There's a waste of a pump, right? Like barely max sparing for more than 2 hot seconds, non-analgesic, and usually makes dopey sedation and dopey recoveries. Like, thanks, but no thanks.
Wow.
Yeah, and unpredictable in most instances, unless you're a neonate, a severe geriatric, or literally half dead on the table. So it's
or
just
a primate.
Oh, yes, thank you. Okay.
Or a bird.
Yeah.
Okay, this is a fun game. Anyway, back to lidocaine. But the other thing too is, like, let's say I didn't want to use ketamine as my co-induction agent because, like I said before, you're already arrhythmogenic, or whether I think you're in really like closer to end stage heart disease where I worry about overworking the heart when it's already going to be strained under anesthesia. Maybe I'll pick lidocaine in that instance, but it's not my first line co-induction agent.
So
but
like
it is for sure an option that I will, use.
So you never use it?
Not infrequently, but not frequently.
I've worked places where it's
very diplomatic.
That's like their go-to. Like, it's like 50-50 whether you're going to get benzo or lidocaine as your co-induction. And it's just like, all right.
There is the influence of where you trained, right? Like, there are certain schools where lidocaine is their absolute go-to. And I happen to work clinically with 2 anesthesiologists who trained in one of those schools, and they will, like, it's like a hose of lidocaine on most of their cases. And I make fun of them all the time because I'm like, guys, be creative, like mix it up a little, like use dexmedetomidine once in a while or do something. But like, when I'm on clinics and and I'm covering for them and they're off, like I have to control the RVTs from putting everything on 200 mics per kg per minute of lidocaine, because I do take, that is above toxic threshold. And even though it's published, if anything were to happen to that patient and I sat before a regulatory body, which is made up of non-anesthesiologists, and they actually figure out it's above toxic threshold, I will not be able to weasel my way out of that liability. Yeah. So that's the other consideration. I try not to practice fear-based medicine because of liability, but I feel like that is a real hot red flashing light.
Yeah, it is. So, but so you going back to your benzos, right? For a second,
Bailey, he's hijacking your podcast topic.
Who the fuck cares about lidocaine, right? Like,
hey, I've got lots more questions about lidocaine. I have a whole prepared. So, like, all right, how about let's talk about some instances where I love a little lidocaine.
Let's do it.
Dogs with a brain tumor. You're going to induce anesthesia.
There you go. That's a good one, Bailey. I like
Okay.
that.
What's your
Yes.
thoughts on using
I'll take
lidocaine
it.
as part of your co-induction to decrease laryngeal reactivity?
I'll take it. Yes.
Yeah.
All right.
Or
And that's about it.
if you have a patient who's really like coughing significantly, I will actually use lidocaine sometimes in bronchoscopes. I've actually, in human medicine, they spray the lidocaine down the bronchoscope. So I've actually taught a lot of internists about that so that I don't have to increase systemic plane of anesthesia. We can just locally desensitize cough receptors. Quick aside. But no, I like the antitussive component. Also, okay, so I know a lot of people talk about things like ketamine raising intracranial pressure, but there's that paper that shows that across the board, just the process of intubating raises intracranial pressure, and it's fairly equivocal based regardless of what induction or co-induction agent you use. So I don't overly sweat it. But yeah, I think that's a good one. Where else do you like spread the lidocaine love?
So like again with those antitussives, I like to use it for retroflexing, like in dogs, like when they have to retroflex into the nasopharynx. Again, it's just that I can annihilate them with ISO and they're still going to cough and gag. And then like a little bit of lidocaine in those situations, they tend to, it just gets them through. Like
Where do you put the lidocaine though?
Like in their veins.
Oh, okay.
Like just a little IV lidocaine, and it's like, so it's either like stupidly, it's either the lidocaine has an effect on that, like the antitussive effect, like Bartel's talking about, or they just get just so deep so quick, and then
it's probably not that one, but okay.
It could just increase anesthetic depth enough. Like I don't know. I personally find inhalant is not the end all be all of anesthesia, and sometimes you need injectable anesthesia to get a patient to stop reacting to specific stimuli. Like I find
Beanie and I are not into inhalants. Like we're the Tiva podcast. Like, are you there? But I mean, think about the local spraying though. Like, see whether or not you guys have a scope. Like, instead of like flushing water, you can actually flush a dish of topical local anesthetic. Because I also find, as a side note, when we do things like I'm going to do an intraorbital nerve block because you guys are going to do like nasal biopsies or whatever, and I'm like, what a crock of shit that is. So.
So wait. What?
And the maxillary does not affect the medial part of the septum. So if they are taking caudomedial biopsies, that block was a total waste of time.
That's
right?
Fair.
I think
That's
it's
fair.
more efficacious.
I think the paper was from PJP or somebody.
Well, I'm sure he loves that. Like he put out so many papers about that block. It's interesting.
No, but I think it's probably more efficacious to actually have them like almost atomize it locally on the area that's affected, right? Bearing in mind, though, that tissue may get edematous, but honestly, they're ripping out hunks anyway, so you're probably destined for edema.
For sure. Absolutely.
Yeah, no, that's interesting. So, do you even use lidocaine for your blogs? Right? Like, I think it's totally, I mean, at least myself, I totally switched to ropivacaine. I never really actually even
not often.
Lidocaine.
I don't use it often, except if we're doing something, pardon my français, a little bit fast and dirty, and I've been caught a little bit more off guard, and I want instant efficaciousness, right? That's probably the only time I'll reach for lidocaine as a block, right? The rest of the time, I'm either using like a medium duration one, like mepivacaine, and then the rest of the time, bupivacaine. But
why mepivacaine?
Because it lasts a wee bit longer than lidocaine. So, for example, like the walking epidural, you might want to use like a medium length local as opposed
to... I meant like compared to ropivacaine. Sorry.
It just depends on which one's more available clinically, really.
Gotcha.
The difference between mepivacaine and ropivacaine for me clinically is fairly indistinct. So it just really depends on what I have on the shelf in that hospital, if at all, right? A lot of places.
So you're not looking at like their PKA and all that stuff, right?
Yes, no, I definitely am. Definitely looking at the PKA. It's nothing I love more than thinking about relative PKAs when I'm clinically doing something. Yep.
But so Yeah, no, so for whoever is listening, I think mepivacaine supposedly actually performs better than ropivacaine in an acidic environment, right? Slightly better, right? Because the pKa should be a little bit lower, right? Compared to, ropivacaine and bupivacaine. So mepivacaine, it's actually performs a little bit better in that case.
I'm gonna go ahead and
But
trust you on this one, Beanie.
I mean, the other thing too is it's less chondrotoxic than ropivacaine and bupivacaine. So if you were doing
true.
something that involved a joint, that would probably be the other option. Personally, my favorite local anesthetic is Articaine.
Oh,
Wow.
Suck that one, boys.
achieving so dentistry.
I feel so like a Neanderthal. I'm like, well, I got lidocaine and I got bupivacaine, and you know what? They do pretty good.
But like, think about it. Let's talk about cows for a second, right? Like, are you going to do like a distal paravertebral or an inverted L block in an emergency C-section where you have to put in like 4 billion mils of local anesthetic to block the damn cow so that they can actually have their cesarean? With mepivacaine or bupivacaine, you're not, because it's volume prohibitive and cost prohibitive. You are going to rock lidocaine. We're being very, very small animalist, and I don't want to ignore our one cow person out there who's listening. But yeah, I would. There's a nice indication for farm animals where it is large volume is necessary. You need really fast onset because the patients for in those kinds of you got to go fast, and also the cost. Lidocaine is probably my preferred agent in those instances. Ooh.
Here they still use mepivacaine, by the way. They use mepivacaine in large animal all the time.
Well, you are
So
the
I
one
don't think they carry
cows, whereas I'm just up here in 25 centimeters of snow. So that's good to know.
But the other cool use of lidocaine, for example, some people nowadays they've been using it, for example, like in fish anesthesia.
Oh.
So there is a protocol where you actually pair with propofol for immersion, which has been described, and I heard it works pretty good. People are trying to move away a little bit from MSCQ2 to try different things, or there is some interesting research going on that stuff. So another use for locals.
Why do you know that? Are you reading the fish anesthesia journals that we're not? Why are you abreast of what's happening with fish?
Well, I mean, besides the fact that I really like aquatics, I have all the aquatic books. I read that stuff all the time. It's pretty cool. But I also teach the aquatic and.
This is news to me. I didn't know you were some sort of
Ah,
fish fanatic aficionado.
yeah.
Did you know this, Ryan?
I did not.
There you go. But yeah, I teach the aquatic anesthesia lecture at Ohio State. So even though I left, I still teach that. Actually, I taught that.
How much fish anesthesia are you actually doing clinically, though?
Now very little, but in the past we did a bunch.
Why
before
and how and where?
Well, some of the stuff was research. So they had a huge colony of fishes at Ohio State and stuff like that. Not specifically Ohio State, but it was the children's hospital that had a huge research facility that had 55,000 zebra fishes and stuff like that.
They're all the rage in research for what I know. Those zebra fishes.
Why do you know that? And why don't I know either of these things? I can't decide which part is more concerning, my ignorance or your lack of.
When I did my lab animal rotation, they were telling me all about these zebrafish. They were like, oh yeah, zebrafish. They're all the da-da. And I was like, zebrafish.
The cool thing of zebrafish, actually, fun fact for whoever is listening, is that, especially when they're young, they're transparent.
Yeah.
And so basically you can tag their CNS with fluorescent genes. So there's some genes that can express fluorescent in their CNS. And so they can look at how the CNS actually develops visually. You don't need imaging, you just look at it. So there is some bunch of studies with like how ketamine affects CNS development and stuff like that, and like you can see it visually, so it's pretty cool.
That is very cool. I will concede to that. Although if I were to have a child, make me laugh, and then it needed anesthesia, and I was like, "What's the research?" and someone was like, "Oh, don't worry, we tested zebrafish," I would clench my butt pretty tight.
For sure.
Fair.
So
Fair.
other things I feel like we should talk about, since we are, experts, if you will, in local anesthetics. So what does the team here feel about Emla cream?
The eutectic mixture of local anesthetic.
Of course, yes.
Oh.
I know I'm reaching a little bit on that one, but it just felt like a reasonable thing to bring up. Like, it was 5 years ago, it was all the rage. Like, everything was getting.
Works when used appropriately.
And how is that?
Well, you basically have to put on, I mean, it's heat activated, right? Because you have to get to the eutectic point of the two local anesthetics, which means it does have to be warmed. So, and it needs time to work, right? And most people are like, they slap it on with some vet wrap for 10 minutes and hope for the best. And I'm like, you probably need about 40 minutes min. And you probably want to do something like a saran wrap occlusive dressing and then allow it to come to body temperature so that it actually activates, but then it also has to percolate through the skin. And of course, if this were a zebrafish, there's going to be variability uptake versus like a bulldog versus a Yorkie versus a cat versus a cow who has leather for skin. So Emla cream, if you have the luxury of time, which so many of us do clinically. Right. I think it would be a very kind thing to, numb the area of catheter placement, because I do think catheter placement is somewhere between uncomfortable to mildly painful. Like if you put a catheter in me, I will hold my breath and go to my happy place. So, yeah, I think, like I said, if you have the luxury of time and you understand what eutectic means, and you actually use it appropriately, and it actually works, which I find it rarely does, then I think that would be lovely for all of our patients in anesthesia never land.
I think there was a paper, they used very heavy, what I would describe as fairly heavy sedation, but I think they showed it might work as little as 30 minutes in dogs, if I'm remembering the paper correctly. Yeah.
It's like I said, I usually give it a good, like if I'm really going to do it, I commit to it. I like to give it
for sure.
40 before I go for the poke.
Yeah, absolutely.
Yeah. I err on the side.
Are you using a much beanie?
No.
That's fine.
No. I mean, I think they're clinically enough.
No.
Like I've worked places where like, oh, we'll use it all the time, and then it's like a fad. Like it comes, it's like, oh yeah, we're gonna use this, and then people use it, and then like they forget about it, and it's
by
like.
fad you mean a fish anesthesia device? Or...
God.
Waste of a pun.
All right. I mean, I know the answer to this one, but I'm gonna ask it anyway because I feel like it's probably out there, and there's people who listen to this who probably want to know. Lidocaine patches for animal patients.
Ooh, so in humans.
Just so you know, I wasn't done with Emla cream. I will say I found it very efficacious for my own personal mosquito bites, which I think clinically has been my greatest use to date, because I really dislike itching and I really dislike being bitten by arthropods. So I will Emla myself if I'm, surviving a mosquito attack, just so everybody knows. But yes, lidocaine patches. Sorry. Done. I'm done with Emla now.
I think
we can talk more on Emla. I just feel like there's not much more to say. Like,
I think so Emla, I would use it if we had it. We don't have it, so like the lidocaine patches in humans they work great. I think there are some issues with absorption with skin.
Yeah,
and animals, and so like. I can't say I've ever used one in an
Oh
animal,
yeah,
really. In humans, all the time. Like I think, like even both me and my wife have some back pain, and they work legit good. But if the absorption isn't great, I mean, what do you do? There
yeah,
isn't really
sure.
much you can do about it, right?
I have not used them clinically. And I guess my questions about lidocaine patches, I'm not fearful of them. I'm not sure it ever occurs to me, but it's a reasonable consideration. I think we don't have, I mean, there are some papers out there that have looked at it, but again,
Yeah.
how are you supposed to know what uptake is going to, or efficaciousness is going to end up being for like a morbidly obese, unneutered bulldog
Right.
versus like a petite Yorkie with that thin paper see-through skin? Like, I don't have any idea what
Yeah.
plasma effective concentration, what are the pharmacokinetics and pharmacodynamics associated with these patches? And, looking at 5 healthy beagles in the lab doesn't tell me much about anything in dogs clinically. But I wonder whether or not the place that we could really be using it to a greater advantage would be horses. Um,
So,
okay, yeah.
so I do. I think I wrote a presentation a while ago, and they actually looked at patches versus Emla cream for. I think it was like a.
You wrote this?
No, I looked at. I
Oh,
wrote it. I wrote about it in a presentation I did, and
gotcha.
I think they, if I remember right, they were doing like a vaginal surgery on these horses. So they were either applying Emla cream or putting the patches on, and they found that Emla cream was far more efficacious than the patches.
Well, that's because you're putting it on mucosal skin, not skin with proper epidermis, right? So it like perivaginally, right? That's a
Yeah,
different kind of skin than it
yeah.
is
Oh,
like
for sure.
over
True.
your kneecaps. But I'm
Yeah.
wondering what the utility, for example, of a lidocaine patch might be, because we still struggle a lot with pain management in large animals. And I still, to this very day, have to argue with equine surgeons about whether or not butorphanol is sufficiently analgesic for major surgery. P.S. It's not. Um, but, they get so upregulated about opioids and colic, even though, in my opinion, pain is more likely to cause a severe
We
colic.
give we
I
give
see it
morphine
all the
to
time.
every single horse that's painful, and if especially if they are having colic surgery,
Yeah,
right? And
100%.
and the pain definitely does cause way more colic
No.
than the morphine
Oh yeah.
does. And again, it comes back to what we were saying the other time, right? Like you would see, because the horse does need that analgesia, you're not seeing as much of that side effect from the opioid.
Yeah, but I
Like,
still also struggle to this day with surgeons who will say things like, they're like digging around in legs and joints and things like that. And right, the horse is, reacting like, like you can see like blood pressure and eyes and going up and down. And I'm like, could you just, like stop plucking that nerve and maybe, put some local on it so that I don't have to keep loading the horse systemically so its recovery isn't going to be a hot mess. And they'll be like, no, 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 I want it to do that. Right? Like I want it to be reactive. All right. I want it to be reactive and painful. And you're like, oh my God, how can we still be having this conversation in 2025? But I'm wondering, like, what if lidocaine patches are a nice way to deal with, post-surgical wound analgesic management and that way we can spare the systemic drugs and some of the adverse effects and potential concerns associated with it. I don't know.
yeah, that could be, yeah, it could be an option, I guess. I mean, although at that point, a lot of the times you just do a local block, right? And so um, I don't know if the Lidocaine patch was, I mean, uh, if the local block was fine, most of the, you don't need that extra analgesia probably, right? You know what I mean?
Yeah,
But
yeah,
once
yeah.
that wears off, then I can see it, right? Like, the unfortunate locals don't last forever, right? Even if
Yeah.
you use something like a liposomal bupivacaine, in reality, it's not infinite, right? At some point, wears off. So I guess the lidocaine patch would be um, probably a good addition. I mean, do you still have those concerns that you would have with like a fentanyl patch? Like, if you send it home and a kid's eat it or another animal eats it, you know what I mean? Like,
Yes, but probably, I'm always worried that anything that you put on an animal, they may groom it or eat. I don't
right?
worry as much about horses. Like they're
Nah,
not indiscriminatory eaters the way like a cow is, right? Like cows will just swallow a bucket of nails and not even care. But, dogs and cats for sure. And yeah, of course, I always have a concern that anything exogenous, externally placed, and has potential complications associated
yeah,
with it if kids or even adults with issues come into contact. I don't want to do harm to either that pet, another pet, or any other person in that family. So
right,
yeah, but am I as worried as fentanyl? Anecdotally, probably not. Is that correct? I don't know.
right, fair. So I want to ask another question to Ryan, right? So now you brought up the topic of lidocaine, right? So
Yeah.
how do you deal with lidocaine IV in pregnant patients? Would you use it as a co-inductor for a
Straight up,
C-section or
do not. I feel I cannot think of a situation in which I would reach for it. I think there are other drugs that I would prioritize above lidocaine in a pregnant bitch, especially because of, was it ion trapping or whatever? Because the pH of the fetal blood is so low that
Right. Yeah, the pKa gets shifted because of
yeah.
the pH of the environment. You have to explain it to the listeners there, Bailey.
Yeah. Well, I was getting there. I was saying the blood of the neonates is so low, the pH is so low that the lidocaine ends up accumulating in the like neonates or like the preborn puppies essentially, and so they have higher systemic concentrations relative to the pregnant bitch or whatever. So yeah, I would not. That would not be a drug I add to my not one I'm using personally.
Gotcha. Yeah, and so I mean somebody that has the argument.
In this
Yeah.
is this the one time where you randomly reach for lidocaine? Do you use it
What?
do you use it for
No,
dystocias?
no, are you crazy? No.
Okay. I was like
You're crazy.
I haven't had a glass of wine, but I feel like I might need it after this conversation. Yeah.
No, no, no. I mean, I don't use it as is anyway, but
Yeah. That
especially in
lidocaine
those,
bottle in Beanie's clinic still has a bunch of dust on it. It's never.
they expire.
Yeah.
They just
It
fucking
was the
expire.
first bottle.
Funny
I
anecdote,
think, to be honest,
tangent. When I first moved to Singapore, they literally like their bottle of ketamine. I think it expired before they even opened it, right? And
Hell
then
yeah.
after the first month of me being there, they're like, "We have never gone through this much ketamine in the history of the hospital." And I was like, "What?" Yeah. But it was like I like blew the dust off, and then I just opened the ketamine party to Southeast Asia. But yeah, I could see Beanie being like, "Ugh, lidocaine."
So one other thing to just talk about for the listeners out there, mixing local anesthetics.
Uh,
I feel like we just
oh,
I know. We're all gonna be like, it's terrible, don't do it. But like, why?
why?
I mean, I know
because you
why.
mess up with the you mess up with the whole pharmacological profile of the drug, right? Like, there's studies where people were trying to do this, but by pairing like lidocaine and bupivacaine, for example, right? Hoping that that would normally lidocaine has a faster onset of action and bupivacaine has a longer duration of action, right? And so people were trying to achieve the duration of action of the bupivacaine and the fast onset of lidocaine, right, by mixing them. And in reality, the study showed that the duration is shorter and the onset is longer. So like it's totally the opposite of what you want, really,
And
right?
toxicity
And
is
so
mostly synergistic, which means you're more likely to have
exactly.
an ish if you mix them. Now, Bailey, I have a question for you. I'm going to tease this out a little bit.
Oh, all
When
right.
you say mix local anesthetics, do you mean as described by Gianluca, which is you basically take a little Lido and a little Bupivacaine and you shake
Mm.
it up and you inject it? Or Do you mean I gave an epidural with bupivacaine and then I put it on a lidocaine CRI?
So both are great
Boom.
points. What I was specifically referring to is some practices where people do mix two drugs in the same syringe and administer them as part of
Let's
their
call out
life.
the ophthalmologists because that's who's doing it.
For
So
dentists.
Uh,
let's talk about using local. So that's actually a really good question because a lot of those patients who are going to get both IV lidocaine and local regional are patients that I think a lot of us are going to say this patient is at risk or probably is already experiencing some degree of chronic pain, right? Like to my mind, that's where I'm going to be. Like that's where lidocaine is often used in my practice is
well, Bill, if
patients.
it has chronic pain, why don't you just give it half a mg per kg of sub-Q ketamine?
Every 2 weeks. Every 2 weeks.
Yeah, exactly. But like those hind limb amputations, right? Like that patient, chronic pain, phantom limb, whatever you want to like talk about, like I would easily put that patient on a lidocaine infusion.
As opposed to
Probably
ketamine.
ketamine's the first one. Sometimes I do both. It just depends on my mood a little bit. If I feel like making a combo syringe and putting it together, or just like ketamine's always there because there's evidence for it. Lidocaine's hit or miss for me, but
So would you block the leg? So let's say you're doing a hind limb amputation and
for
you're
sure,
doing something like a parasacral sciatic and a psoas
yeah,
compartment, right?
sure.
And then you want to put them on a
I was just
lidocaine
epidural on my end, but yep, all that stuff sounds great, Bartel. Very good.
basic. And
Never said I wasn't.
and then you also will put them on the lidocaine infusion. Is that kind of the thought process? Because that's my question is when we talk
Yep.
about mixing, technically
Yeah.
speaking, like if this were a board exam,
Sure.
which I'd rather swallow glass than sit there again,
Sure.
and that this question
I
came
thought
up,
you loved it.
yeah, it was the best. There's nothing more I care about than NSAIDs and the giraffe for 10 straight hours.
Hey.
But yeah, if this were a board exam question and they said, would you give a bupivacaine based epidural and then put them on a lidocaine infusion? Technically speaking, in the purest sense of the word, my answer to that would be no, because you're not meant to mix local anesthetics.
Mhm.
However,
Right.
I've done it
Sure.
because I'm wondering, like,
Yeah.
what is your systemic uptake of the bupivacaine? And I'm
Well,
also
so
using it for different purposes.
right. So that's a known quantity, though, to some extent. Like we know, at least extrapolating from human literature, we know that the highest risk of local anesthetic toxicity when administering it for local anesthetic is doing bilateral intercostal nerve blocks. That's the one where you see the highest plasma concentrations, if I remember correctly from the human literature.
There is a study, actually, now that you mentioned this, there is a study looking at absorption of IM pre-meds and how different muscles group actually absorbs differently.
Oh yeah,
And then
for
the
sure.
costal is the
Versus
fastest,
leg,
right?
blah, blah, blah.
Yeah, I remember. So are you worried about so I guess my question is, are you worried about systemic toxicity or are you worried about I mean, they're not going to alter the PKA though because you're not going to get them at the same site of action. Like
No,
Yes,
no,
I'm
at that point it doesn't.
maybe if the local has gone neuraxially, or in other words, am I doing a spinal or an epidural? Because
yeah, sure.
it's such a small whisper of a volume to begin
Right.
with.
For sure.
And what systemically is that going to cause me a huge problem? No.
Right.
However, if I've been doing a big series of blocks, right?
Sure.
So let's
Yeah.
say I've been doing, I don't know, bilateral tap where I actually go for the zero 0.4 mils per kg, which works out to the 2 mgs per kg of bupivacaine. But then I also have a patient who happens to go into, I don't
Sure.
know,
Yeah.
VTAC.
Yeah.
I cannot put them on a bupivacaine CRI. I mean, to be fair, it will resolve the VTAC forever.
Yeah.
But I can't do a bupivacaine CRI. I've already blocked their abdomen because I was expecting, like, I wanted to protract, for example, surgical recovery analgesia. And now I'm kind of stuck. So do I do it? Yeah. Do I worry about it? Honestly, my worry's pretty minimal, even
Yeah.
though, there's potential. And like I said,
Yeah.
I have a healthy respect for the local anesthetics and their ability to really stop your heart in a one beat situation. So
Yeah.
I don't know.
I mean, I would be worried if I was doing an open chest case and we did bilateral intercostal nerve blocks and then the patient went to VTAC. That would be a scary situation because that's the one where we know they have the highest concentrations. Like I think it's intercostals number 1, and then I think it's brachial plexus number 2.
Anything where you're close to either major arteries or
Yeah.
pleural, right?
Yeah.
A mesothelial uptake, right? Which basically is pleural or peritoneum. We know that, for example, like when you do like an infusion or an infiltration through a chest tube, or you quote, do the splash box that they used to do, a closure of for spays,
Yes.
mesothelial cell uptake of local anesthetics is significantly more rapid than skin cells, right? And so they're short acting, and you can actually get, like, people have seen local anesthetic adverse events,
Yeah.
neurological, cardiac, associated with some of those blocks because of it. That being said, I don't really do many intercostals these days, right? I'm
Yeah.
probably doing a parasternal ultrasound guided now for sternotomies, which is really fast and easy and really lowers the volume. And it's because you're at that deep bed of the musculature, I'm not right up against the pleural mesothelium, so I don't worry as much. The brachial plexus, 100%, because you got that whacking big fracking blood vessel right in there. And like, even when I mix dexmedetomidine with my bupivacaine for that block, which, side note, is my most hated block, I can sometimes see like the drop in heart rate because of the dexmedetomidine uptake just from
Oh
it
yeah.
being adjacent to the artery, right? So it's legit. But yeah, like
Yeah.
I said, mixing locals in this capacity, I haven't yet encountered a problem, which is not a great justification.
Right.
But am I worried about it? No, not a lot. Not a lot. I don't stress about it too much. But like I said, if this were a board exam, I would sing you a different song for sure.
Man, speaking of side effects, I didn't even get to like how often do you really see the GI nausea, vomiting side effects that everyone worries so much about with lidocaine and like all those other things that people are very highly stressed about that we're like, all right, we're going to put them on 100 and we're going to move on.
I mean, our patients are awake, so there's that, right? So for sure, I can crank those. I mean, I'll put fentanyl at 20, which I would never do in a awake patient because it would not move.
It would no longer be an awake patient.
Yeah, it wouldn't
Ah!
be but so we can get away with doses that are not appropriate for sentient
Oh, I agree.
patient.
Yeah.
There's that. Now, the whole thing about nausea, it is dose dependent. And it pisses me off so badly. Like, this is one of those things. Like, this might be one of the hills I die on. When you have a patient who's on like 20 mics per kg per minute of lidocaine, which is probably subanalgesic, and I'm calling out critical care here because this bullshit comes from them. They will stop. And if you can't see us right now, the guys are nodding because they know it's true. They will stop the lidocaine and turn the fentanyl up
Oh my God.
to control the patient's pain, but to abate the nausea. And that has got to be the dumbest thing I have
Yeah.
in my life.
Like, that drives me bonkers. I'm like, okay, guys, we're talking about this patient who's like, fucking intestines are paralyzed and they're not eating and they're nauseous and they're vomiting. And we're like, and here we go.
And it's always the first
fentanyl.
thing they want to stop is always the lidocaine, when I'm like, it is such a bunch of shit because you only see the nausea close up to around the 100 mics per kg per minute. And I'm like, but we're okay to crank fentanyl up to 5.
Oh, yeah.
Or 7, and wonder why
Outrageous.
the is regurgitating, recumbent, and hyporexic. And I'm like, think. I wonder which drug it is.
And it's like, turn it off. Let's add some like light, like let's add lidocaine. Let's add ketamine,
Meanwhile, ketamine can also cause you to be dysphoric, which if in
Oh,
people,
for sure.
they'll often tell you that dysphoria is one of the worst medical experiences you can have. Like being dysphoric, for sure, if you are dysphoric, you are not going to eat. So, yeah, I don't know. I just, this whole anti-lidocaine pro-nausea garbage. Yeah, critical care, guys, you need to stop with it. You need to stop with the lidocaine bullshit. Okay, that's my 2 cents. Beanie?
No, I agree with you. Yeah, I hate when they do that.
One last anecdotal question about lidocaine, and then I will leave it alone. So
You had a lot of questions about lidocaine, more than I was anticipating,
Yeah,
actually.
I didn't
Let's
really
let
crazy.
this conversation go.
So,
We are.
have you seen seizures at induction following lidocaine?
Oh.
So I can share one anecdotal story. I do not think the lidocaine is the culprit, but it just so happened that we pushed the lidocaine, the dog dropped to the ground and immediately started convulsing in front of us. That dog had also, by the way, ingested a metric ton of coffee grounds that we were not aware of. We were going in for a foreign body surgery, and in the intestines, it is literally jam packed with coffee grounds. So I think we know the culprit there, but a
Right.
fascinating turn of events. And then I was recently doing a locum thing, and they had said they were recording instances of lidocaine causing seizures, and that they had seen a rash of it.
A rash of it.
Yeah. Well, I'm sure they used the word
Wow.
rash. That's my, whatever.
Now, that's
But
ableism for sure.
they had seen like a fair number of seizures following lidocaine because they were using as like it was one of their main co-induction agents. And I was like, that's interesting.
Interesting.
I've only seen it one time, and that dog ate a bunch of coffee grounds.
Yeah, interesting.
Beanie?
No,
Cool.
I
And
can't say I've seen that. But
I wouldn't
as
dismiss it though,
again,
right? Like, I mean, I haven't seen it either, but I wouldn't dismiss it because neurotoxicity obviously is one of the
it's fair.
symptoms of local anesthesia toxicity. On the other hand, my opinion on anything that we put into a body that is foreign, exogenous, allogenous, however many adjectives you want to use for it, doesn't belong in the body, I think has potential to generate a reaction, an adverse reaction, right? I think there's a potential for an allergic
Yep.
reaction. I think there's a potential for, especially in the sedative class of drugs, anything that you're doing that is going to change normal brainwave activity. So, for example, this is why if you're going to see seizures, you usually see them at recovery, right? Because you're going like, down here from almost flat brain activity line and you're bouncing back up and you're reorganizing like the electrical syncytium of the brain, anything that's playing with that, right? In other words, as we continue to play God and to the edge of death and bring you back and bring you to the edge of death and bring you back, I think if you are going to interrupt the normal electrical firing of either an awake or an asleep brain, because anesthesia is not really sleep, I think has seizuring potential. Because honestly, at this point, maybe with the exception of lidocaine, I've had patients seizure on butorphanol. And these are patients
Wow.
who sometimes will have an uncontrolled seizure background. Those are usually the ones who are going to have be a hot mess when you go to sedate them or where you're trying to recover them, I find, are the ones who are like known epileptics, but they only seizure once a month, so they're untreated. Those guys usually give me a bit of a pain. And the one time I'll use my benzodiazepine co-induction agent. But I think anything that plays with your brain activity has, can be eleptogenic essentially.
Sure. Yeah.
But I've had dexmedetomidine cause a seizure.
Oh yeah.
I've
Felt that the other day.
I've had anaphylaxis from famotidine. I've gone into VTAC on slow cefazolin, not personally, but slow cefazolin. So every single drug I've seen, I believe because it's a foreign material in the body and because there's only so much we know / fancy guessing, can potentiate an adverse event. So even though it might not be a published outcome of lidocaine, is it possible? Totally. Is it
Oh
possible
yeah.
in
Oh yeah.
non-toxic context? Totally. I question the rash of seizuring events associated with lidocaine. They might want to consider throwing that bottle out, sending it for analysis, reporting it to the manufacturing, and rocking up with something different. But yeah, I haven't seen it, but saying that, it'll probably happen tomorrow. So
Make sure the dogs don't get in the coffee grounds.
Well, that's the other thing, right? Like, it's so hard to really know what's going on when we've done like 3 or 4, 5, 10, 14 different things, right? And you're just like, which one caused the seizure?
Yeah.
Right, exactly. Yeah.
But if you read Plum, sometimes it will tell you that dexmedetomidine lowers the seizuring threshold. And I'm like, where did that shenanigan come from?
Right. I mean, yeah. I mean, I don't know how much credit to give to that, but sure.
No, I had a GP call me up once because this dog who was like a known epileptic but was well managed, and I pre-med because it was bonkers. I pre-med with dexmedetomidine, and the GP called me up and attempted to ream me out about dexmedetomidine seizuring and thresholds. And I was like, oh, sir, boy, did you pick the wrong person for the wrong fight on the wrong day, right? Like, I was like, you don't want to do this. You don't want to do that. But anyway, so that's my 2 cents. Do I think lidocaine causes seizuring? No. But I think it's possible.
Oh, no, I don't think it causes not to say that, but I just wondered if you happened to come across it in all your travels.
Not yet, Bailey, but the day is not over.
I know.
And honestly, there's still, even though I do little less clinics than I used to, there's still not a day that swings by in my life as a veterinarian in the greater culture of veterinary medicine where I do not learn something or are surprised by something. Could be anesthetic, could be non-anesthetic. But yeah, every day to me is like, oh, this is a first.
Right.
So, could happen.
All right, guys, I think we're coming up on the hour. We're done answering questions about lidocaine and its utility/futility.
I hope every podcast and every topic, basically, we never land on any meaningful conclusions. We just basically
there isn't. I think the lidocaine.
Yeah.
So to give a summary, right? So no lidocaine in pregnant patients for sure. It may or may not. It doesn't. So it doesn't. We don't see any nausea unless you go really high on the dose. If you need to pick between fentanyl and lidocaine in a post-op patient and which one to turn off or decrease if you're seeing nausea, pick the fentanyl. And then don't try to mix up local anesthetics, I guess. Although, like if you did a block and did the lidocaine ZRI, that's probably okay-ish. And then what else? Yeah, Emla cream, it takes fucking forever. Bites. Otherwise, it's cool.
Great for mosquito
bites. Great. Lidocaine patches, we should probably use them more, but we don't.
And I will never stash because they're sweaty and disgusting and they trap weird stuff, and that was the worst 4 minutes of my whole life.
Let me tell you, facial hair in the winter is great. Really keeps you nice and warm.
So now I have this last question for you, Ryan. Now that is there any like weird ass like special food or crap that happens in Chicago during like St. Patrick's Day? Or
I mean, we dye the river green.
You do what?
The
poor Italian doesn't know this.
Every year they have this dye that the plumbers use to look for like leaks in your pipes, but it's like an orange dye, and then what's added to water turns it like bright, like neon green, and they go up and down the Chicago River just dumping all the like dye into the river, and the whole river turns green. If you look up pictures, it looks like it's got a filter or like it's some Instagram thing. No, that river is like green, like Kelly green color. It is. Is it
okay for like, the environment?
I mean, They claim it's like non-toxic, I think, and I mean they claim it's okay, but like, man, they're like they
Do
got
it
like a
superficially
cannon,
where
and
we
they're just
inject the green.
posing all this stuff around.
Should use
Yeah.
a zebrafish to see whether or not it's good for the environment.
I mean, the Chicago River is not something you want to swim in or spend any great amount of time in because they used to like dump all sorts of shit in. But like they're trying to clean it up and get it better, but you know, we still like
But
diet as well.
right? Like I think a good rule of thumb circa Paris Olympics is don't swim in poopy dead body urban rivers.
Yeah.
Chicago is no exception.
Yeah.
Although one of my favorite quotes from the movie The Fugitive, which I think is one of A, the best movies, and B, one of the best Chicago movies, Bailey,
Sure.
is when they're at the St. Patrick's Day parade and they're chasing Harrison Ford down, and Tommy Lee Jones is like, well, if they can, you know, dye it green for this day, why can't they dye it blue for the other 364 days? I'm always like, because the rest of the time it's like that gross, muddy river. But I always snigger at that part where they're like, just dye blue the rest of the year. But our younger listeners probably won't understand that cultural reference to the movie The Fugitive. But
All right, guys. I guess thank you so much for listening. We'll see you in the next episode. If you are listening and you want to watch, you can watch us on Apple Podcasts, which I just found out. I didn't really know that you could watch us on the Apple Podcast. But you can definitely watch us on YouTube as well. Yeah. Hope you guys have a good night.
And a good St. Patrick's Day. Did we release the